Welcome to the endovascular management of cerebral vasospasm. I'm Andy Ringer from the Mayfield Clinic in Cincinnati, Ohio, and I'd like to discuss with you some of the technical and medical features associated with this intervention, as well as some pearls to help make it as safe as possible. Cerebral vasospasm is a potentially devastating complication of subarachnoid hemorrhage, most commonly seen after ruptured aneurysms with subarachnoid hemorrhage, in which the smooth muscles of the intracranial vasculature constrict, causing narrowing of the blood vessels, restricting blood flow, and potentially leading to devastating ischemic complications. While this is most typically managed in the intensive care unit with medical management, occasionally this management is insufficient. When that occurs, the endovascular surgeon will have to consider endovascular treatment for the vasospasm and to consider the various options, including vasodilatator infusion or angioplasty. Each of these interventions has its own advantages and disadvantages and must be considered in each individual case. Infusion therapy has historically been performed with papaverine infusion, a direct smooth muscle relaxant that has a rapid onset but a transient effect. This, however, is no longer recommended, as some literature has suggested a cumulative neurotoxicity after repeated use. Instead, currently, we often use calcium channel blockers such as verapamil or other agents such as nitroprusside and nimodipine. They may have a slightly slower onset but a more durable action and appear to be safer when used repeatedly. This can be illustrated in the case here, in which verapamil infusion was performed into the carotid artery for both middle and anterior cerebral artery vasospasm. And as you can see, when waiting a sufficient period of time, up to an hour later, significant improvement in the vessel caliber is noted. Infusion therapy has several advantages. It's safe, easy, and rapid, and it can be delivered from a diagnostic catheter in cases of diffuse vasospasm where much of the vasculature has to be treated. It is highly effective, although may be more effective when delivered selectively to avoid dose loss into high flow areas and to maximize the dose in the low flow spastic areas. And it may be repeated for patients who have recurring symptoms from vasospasm. What's more, it's effective for distal vasospasm and distal cortical branches that cannot be easily reached or treated otherwise. It does, however, have some disadvantages in the fact that it has a transient effect and may have to be repeated. It has a less immediate response and often, when compared to angioplasty, a less dramatic response. We'll show an illustration here of a case of a 51-year-old man who suffered subarachnoid hemorrhage from a small anterior communicating artery aneurysm, who presented in a somewhat delayed fashion and was treated by coil embolization of his aneurysm. As you can see here, the small anterior communicating aneurysm has a bleb on the distal dome of the aneurysm, and this was treated by balloon-assisted coiling. Several days after his presentation, however, he developed new neurological symptoms consistent with anterior cerebral artery ischemia. While his right anterior cerebral artery was moderately concerning, even more so was his left anterior cerebral artery, where cortical collaterals were recruited from the middle cerebral artery due to hypoperfusion. Given his poor response to medical therapy, however, we felt that endovascular treatment was necessary, particularly given the degree of hypoperfusion noted on the anterocerebral arteries, seen here in both the proximal A1 segments and in the distal A2 segments. CT perfusion demonstrated that while he did have areas of hypoperfusion, he did not have a large area of infarction in the anterocerebral artery territories. Based on this finding, we felt that endovascular treatment was necessary, but choosing not to lose dose into the high flow territory of the middle cerebral artery, we felt that selective injection into the anterior cerebral artery would be preferable. And this did have a positive effect, with improvement in the right anterior cerebral artery territory demonstrated by improved cross-filling to the left side. Even more impressive, however, was a response on the left side, where the high degree of cortical collateral recruitment was no longer necessary and cross-filling was seen for the first time. In some cases, however, infusion therapy may be insufficient. In that case, angioplasty can also be considered. Angioplasty is highly effective by countering the contractile forces of the smooth muscle to dilate the artery directly. It has a highly durable effect, and while its mechanism is not entirely understood, it may result in damage to the contractile apparatus that prevents recurrence of the vasospasm in the territory treated. It is, however, considered higher risk as it is more invasive and may result in artery dissection or even vessel rupture. When performed properly, angioplasty can have a rather dramatic effect on severe areas of vasospasm, with dramatic improvements in the vessel lumen caliber, but only along the segments treated with the balloon itself. Our patient with a severe anterocerebral artery vasospasm had multiple episodes of recurrence, ultimately requiring that we treat with angioplasty and resulting in a very significant improvement of the caliber of the vessel along the segments treated. Should be noted, however, I took care to make sure that the balloon did not cross the neck of the aneurysm, an area of fragility that could be highly prone to rupture or dissection. The advantages of angioplasty are that it is durable and sometimes even permanent, preventing recurrence of vasospasm over the areas treated, and it has a very rapid and dramatic response. So patients suffering from severe hypoperfusion may be preferably treated this way. However, it is somewhat higher risk, with some risk of dissection or vessel rupture along the areas treated, and may be more technically difficult in cases where there is tortuous proximal anatomy. It also is a little bit limited in where you can treat, as the distal cortical branches are not amenable to angioplasty as they're highly prone to injury, and in some patients even the anterocerebral artery may be too small to safely treat. It's important to consider when performing angioplasty for vasospasm that it is not necessarily better to be aggressive with the dilatation. In fact, we prefer limited angioplasty to reduce the risk of mechanical trauma that might lead to procedural complications, including delayed complications of intimal hyperplasia with remodeling and restenosis. This is perfectly safe and effective because keep in mind that very small increases in the lumen caliber can translate into a very large increase in flow as demonstrated by Puisseau's law. Thromboembolic complications can be reduced by the use of IV heparin, although lower doses might be required after craniotomy. Dissection risks can also be reduced in the case of infusion therapy by using more proximal arterial access when not needing the more distal access for angioplasty. Angioplasty itself can be made safer by slow, gentle inflation of the balloon and by careful sizing of the balloons to avoid oversizing. Likewise, avoiding oversizing is important to reduce the risk of vessel rupture, but one must also consider the use of compliant versus non-compliant balloons. Non-compliant balloons require a higher inflation pressure in order to dilate the balloon, and many people consider this a risk of greater trauma to the vessel wall. However, keep in mind that that is not true. In fact, the higher inflation pressure represents increased resistance in the balloon wall, not the pressure exerted against the blood vessel wall. Compliant balloons, on the other hand, which have a large diameter change with small changes in pressure, can lead to unequal balloon expansion with potentially devastating effects across artery transitions or highly stenotic lesions. These balloons will tend to preferably inflate in the larger diameter area, and this can lead to overdilation with dissection or vessel rupture. Here's an example of a case where vasospasm occurred in the distal M2 segment. across a transition in the vessel caliber. In this case, a single compliant balloon was inflated across both the M1 and the proximal M2, including the stenotic lesion, leading to overdilatation in the M2 segment, the subsequent vessel rupture. This complication can be managed by rapidly reinflating the balloon across or immediately proximal to the rupture site to provide tamponade and flow arrest, which can be maintained for up to 15 minutes at a time and repeated until extravasation stops. In cases where this is not effective, however, this might result in the need for vessel sacrifice by coil occlusion of the artery to prevent additional hemorrhage. So in conclusion, endovascular therapy for severe symptomatic vasospasm should be considered when medical therapy is failing. Infusion therapy is a safe, easy, fast, and effective method, but it may not be very durable. And in cases where more severe hemodynamic compromise is encountered, angioplasty might be the more effective treatment. This in itself is very effective and durable or permanent, but it must be considered a little bit higher risk because of the greater invasiveness of the procedure. And when performing angioplasty, it's very important to consider the compliance and the diameter of the balloon chosen to match the situation appropriately. Thank you for your attention, and I hope this has been helpful.